food sensitivities don't come from space. They have a lot of precursors and they don't develop overnight. They develop over a month or 2 or 3. Oh yeah, everything from your feet to your neck is going to have an opinion about the fact that your biomechanics just totally changed.
There are so many food sensitivity panels that are out there. It is a multi-billion-dollar business right now.
So you just stop taking it and you don't tell your doctor about it, and 20 years later you end up with dementia or peripheral neuropathies or some form of cancer.
They took blood samples from the same person but sent them from different addresses and different names, and the panels came back different.
You can tell by doing a trial and error thing with your patients and just asking them what they do for fun. That tells you their COMT status.
Right.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
Hi.
Hello.
You have a new hat.
Have a new hat. It's pink and it's girly.
No.
And it's sporty, and it was about time because I just had black and black, so now I've got some pink.
And there we go. As you should.
Yeah.
How are you?
Good. What a great week so far.
Oh yeah. I can't even tell you. Okay, we need to remind me later, and then you go away. Okay.
Yes.
Wow, we're 5 minutes early.
Weird.
Strange. I never show up 5 minutes early.
Because we have so much to talk about today. It's like your subconscious knew to just jump on because we could squeeze every last moment that we have together.
I was on the phone up here with JJ, and so was tidying up the office. And if you'll give me 1 second, there's something that's bothering me.
It's funny how that background, sometimes we just need to make sure. I'm like that with my books. I need to make sure the books are looking as they
like
should.
Symmetry.
Yes.
Symmetry is a good thing.
Yes. So we have a lot to talk about today. And it seems like a lot of the questions that we've been getting in, it's funny how they seem to all have the same sort of trend sometimes. So sometimes we'll get a bunch of shoulder questions, a bunch of mold questions.
It's just in the air.
And oh, what a wonderful segue, because it's not quite spring here yet, although it was quite warm today. Something in the air reminds me of allergies. And I had this very lengthy email about food sensitivities and treating them with FSM. And
look at that.
Thanks for saying it just so clearly. Because, and I think we're doing a good job of saying that FSM is a great adjunct. It does not take the place of food sensitivity testing or elimination diets or medications or anything like that.
Well, and it's also understanding where food sensitivities come from.
Why don't you start with that?
How we develop them. And we have 3 more minutes and there are another 20 people to come.
Right.
But food sensitivities, some are genetic. You just don't tolerate gluten. Gluten and milk are the 2 that are almost genetic. But 85% of your immune system is clustered around your digestive tract. You eat 2 tons of foreign proteins a year. That's a number I heard. It sticks in my head. I don't know if it's right or not. But so if your digestive system, if your small intestine especially, is tight junctions or tight and everybody's healthy and your microbiome is doing what it's supposed to do and your gallbladder's working and your stomach acid is working, then life is good. And then if you get under stress, your steroid levels go up, cortisol levels go up. If you get an outbreak of whatever and somebody gives you steroids, that thins the gut wall and the tight junctions that keep everybody in that should be in get loose and leaky. That's where leaky gut comes from. And then by the time protein gets to your small intestine, it's mostly amino acids and little bits of things. It's not like you're passing pieces of sausage through your small bowel leaky gut. So little peptides go across, and there are antibodies in your immune system sitting there,
Right.
waiting for them. It's a foreign invader. So the antibody or antigen presenting cell, either way it goes. It doesn't help that I found my notes from my immunology class in pre-med that anyway, that you develop a sensitivity to that because it leaked across your gut wall. But there are a lot of precursors that happen before your gut started leaking. It doesn't come from space. Your vagus has to be working because the vagus senses the microbiome, adjusts the pH to keep the right healthy bacteria, and the correct healthy bacteria secrete butyrate and other things that repair the gut wall. And if all that is in working order, then leaky gut doesn't happen.
Right.
So then you get put on antibiotics and you're under a lot of stress because you missed work because you had a sinus infection or a whatever infection, and they put you on antibiotics, and then you're under stress or cortisol goes up and you're on antibiotics and your vagus gets turned down, and then you have leaky gut. And then 3 months later, all of a sudden, something that didn't used to bother you now makes you bloat and have gut pain.
Right.
Or itch.
Right.
Or worst case scenario, get hives.
Right.
So there's IgE responses, which are pretty immediate. You eat a shrimp, you turn bright red, you fall over. You drink milk, instantly you have gut pain and bloating and whatever. Food sensitivities don't come from space. They have a lot of precursors, and they don't develop overnight. They develop over a month or 2 or 3. And then once you have the antibodies, they stay circulating. They go looking for the foreign invaders, right? So for IgE antibodies are easy. You just don't eat that ever again because those are one antigen, one antibody, and they're more or less permanent.
Right.
IgG, those form complexes. They have multiple sites for complexing. And then the macrophages eat the antigen antibody complexes. Macrophages blow up, release histamine. That makes you feel achy all over because histamine stimulates class C pain fibers. And histamine is the neurotransmitter that creates alertness in the brain. So you don't sleep well. And that means you don't make growth hormone. And you also, during deep sleep, you don't clean the glial cells in the glymphatic system in your brain. And so IgG antibodies that's, I think, what people are mostly talking about when they talk about food sensitivities. Those are different than allergies. Boy, I'm really sounding pedantic, but it's just a tutorial.
It's good because we have a lot of lay people listening, a lot of practitioners listening, and I think there's just a lot of buzz and noise about food allergies, food sensitivities, and the differences between the two. So you're doing a great job
Oh,
breaking
yay.
it down for everybody. Keep going.
So food sensitivities are, generally speaking, IgG. And the problem with that is you have a pizza on Sunday without a gluten-free crust, and you don't feel really horrible until Tuesday, at
Right.
which point you forgot that you had pizza on Sunday and you think about what you had for breakfast. That's not the thing. Long story short, let's say that that's what an elimination diet is about. There are 7 of the most common food sensitivities: wheat, milk, corn, soy, citrus, and I think either strawberries or peanuts. One of the peanuts are an IgE
Right.
allergy. Yeah, allergy, but I think it might be strawberries. Anyway, so you completely eliminate those from your diet, like zero, zip, none. Reducing doesn't count.
Yeah.
0 for 6 weeks. Why 6 weeks? Because after 6 weeks, those antibodies get bored. And they said, I don't know, there's no wheat. I'm only programmed for wheat. What are you programmed for? I'm programmed for milk. There's no wheat, there's no milk. Why don't we go in the antibody lounge and watch TV and play pool and just hang out? Okay. So after 6 weeks, they all just go in the antibody lounge and they're napping and playing video games and doing whatever antibodies do. And then at the end of 6 weeks, on let's say a Sunday, you pick one, let's say gluten. And on Sunday, you can have a pizza and you can have a sub sandwich and you can have wheat 2 or 3 times on one day. And then there's a kind of immune cell called an antigen presenting cell. And it says, oh my God, there's gluten. Hold that, wait, I'll be back. And it goes into the antibody lounge and the bone marrow and the thymus and wherever the lounge is. And it wakes up the antibodies. And they go, oh, wait, huh? What? Wait, okay, wait. Let's brush your teeth, comb their hair, take a shower, get dressed. Okay, now, takes them 24 hours to 48 hours. No, 24 hours to get out of the antibody lounge. Then they circulate vigilantly, looking for wheat.
Right.
You're on a rotation diet, so there's no wheat anywhere because after 24 hours, you should, if everything is moving correctly, you should have pooped out whatever wheat you ate.
Right.
And they circulate for 3 days and they say, I don't know what he was talking about. There's no wheat. So they go back in the antibody lounge, but it takes them another 3 days to get all of them back in the antibody lounge, including the guys at the back end that wait just in case.
Right.
And then the following Sunday, you have wheat again.
Right.
And they go through the same process. Antigen presenting cells, wake the antibodies up, brush their teeth, comb their hair. It takes them 24 hours to get out. And that is the basis of rotation diets.
Right.
So you
Right.
can have whatever it is you're sensitive to roughly once a week. That's safe. Some people say once every 3 or 4 days. Now, the FSM adjunct to that is you treat the leaky gut,
Right.
you treat small intestine to repair the lining,
Yeah.
you treat the vagus. If the person with food sensitivities also has Ehlers-Danlos or even hypermobility, you have to treat that. If they have body pain or stress, you have to treat that to get the cortisol down, because repairing a leaky gut, if you look at David Musnick's slides, he runs 124 and 22 on me. I ran it an hour a day for 3 months, every day for 3 months, and stayed away from the foods I was sensitive to.
Right.
At the end of 3 months, I could eat bell peppers, and I hadn't been able to eat lectins, bell peppers, nightshades, potatoes, bell peppers, whatever is in that group. Hadn't been able to eat those in 10 years.
Wow.
And after 3 months of FSM as an adjunct,
Right.
I could eat these foods I hadn't been able to eat in the past. I'm still gluten sensitive,
Sure.
and I've got the gene for it.
Right.
Not celiac, but it's HLA-DQB4
Yes.
or 5. The
I think
one
it's
that
4.
it's 4, right?
I have it.
Yeah.
Too bad, kids. Sorry about that. 2 of the
Sorry
3
about
are
that.
off of gluten. The third is protesting. She's like, I'm fine. I'm like,
Okay.
I thought I was too. And the thing about, and I don't want to step outside of my lane, but one thing I will say about people who are curious about food sensitivities and food sensitivities, let's just say, or food intolerances, is some people think that they're fine because they don't know any different. They don't know what better could feel like. And that was sort of me with gluten. I would have flares here and there, but nothing I could put my finger on. But when I went off of gluten, and it was for 6 weeks, after about 2.5 weeks, I had this revelation that I've been walking around in a fog for so long. So like that brain, like the brain fog was the first thing
Oh,
I noticed. And to piggyback on what we were talking about last week's podcast about how some people, when they recover from something chronic, become angry because of the time that they had lost or however much money they had spent or whatever, there's that anger component. I also felt angry that I didn't realize how badly I was feeling. So
yeah.
to piggyback on how FSM can support patients, you're talking about all those like mechanical properties with leaky gut, vagus, immune support, the emotional factor that can sometimes come up. People
Mhm.
sleep, all of a sudden they have way more energy than they know what to do with. So maybe that, and so maybe that doesn't seem like a problem, but some people are just like, instead of struggling to stay awake at 8 p.m., I'm wide awake. I'm like, okay, so now we have to talk about habits
Sleep
and sleep
hygiene
hygiene,
and
exactly, running the concussion protocol at night, all these other steps to take.
how your world changes. It's the patience when your brain processing speeds up because your brain's not inflamed.
Yeah.
All of a sudden, you have to, or you end up noticing people whose brain processing speed is slower than you.
Yeah.
And you didn't know you were impatient, cranky, or they were stupid. But now all of a sudden, oops,
You
yeah,
become sensitized to that.
yeah, you notice the difference and you get to develop patience and compassion and slow yourself down deliberately and be in the moment and
Yeah.
communicate different. It's not a one-step process.
No, and that's why I thought this would be a good sort of jumping off point because so many times people think that it's just running histamine, running 9. It's not allergy, it's not histamine. Yes, that's a component of this ginormous cascade and this circle that you talked about. So thank you for the stories. And we now have the antibody lounge and the hypervigilance. But that's why you're such a great teacher, and that's what makes talking about complex immunology digestible for the practitioners and for the patients that are listening, because I don't think patients get that explanation readily. And there are so many food sensitivity panels that are out there, It is a multi-billion dollar business right now. So please don't ask us what food panel that we like, because I outsource that to my functional medicine friends. So you can search that
Well,
yourself.
I'm a dinosaur because back when I started doing food sensitivity testing, IgE testing is easy. Anybody can do that. It's immediate. That's where they do all those little pricks on your back, and
Yeah.
that's IgE. IgG, I used a number of labs, and Vince Marinkovich was board certified allergy and immunology. Most MDs go one way or the other, and it's a completely different thought process. He did both. And he taught for Jeff Bland at the symposium. And basically, Vince Marinkovich saved my life. And he had a lab that did IgG testing, and it's immunofluorescent, whatever. So you have a plate with little wells in it, and you tag gluten, wheat, corn, whatever, and then you put the antibodies to those that are tagged with fluorescent dye, one or the other of them all. And the way the machine dips into the well, it has to be precise. Somehow his lab managed it. Every other lab I used, you might as well throw darts.
Right.
So I ended up using Vince's lab until he retired in about 2006 or 7. And I tried labs since then, darts.
Right.
So I haven't found an IgG lab. I know the functional medicine folks must have ones that they like that are accurate. The elimination diet is good for the common ones. You just stay off all of them for 6 weeks.
Right.
And most people can do anything for 6 weeks.
For sure,
But
especially
then,
if you start to see a difference in their quality of life. So maybe the first couple days is a bit tricky.
that's the other thing, is to recognize that when you have, let's say you eat bread 3 times a day, IgG antibodies have multiple sites for complex A, and all the sites are full.
Right.
As you stop eating gluten or reduce it, then you have spots that are empty and they want to share. So you actually can get worse in the
Right.
first 2 or 3 days of an elimination diet.
Right.
And you have to warn patients about that.
Yeah.
And then once all the sites are empty, then everybody ends up in the antibody lounge. But that's easy if it's those 6 or 7 foods. But if it's something where it's lectin sensitivity,
Right. Yeah.
or it's nightshades, or
Yeah.
something because the patient has mold,
Yeah.
and that affects them. There's a number of other factors. I make it sound simple, but
No, for sure. It's very complex. One of the sports performance specialists with one of the professional hockey teams I consult with would talk about the Cyrex panels. That I think Dr. Mesnick likes this one as well. They're very robust. They're one of the OGs. And Dr.
yeah.
Borgiani, who started Cyrex, became so passionate about food sensitivity testing that he developed a wide variety of panels because he realized that you can't just test carrots that are raw. You also have to cook them because some people, even carbohydrates denature. We think about
Oh,
protein denaturing, but
yeah.
carbohydrate starches denature. That's the one that I do see a lot of in the sports teams is Cyrex, just because it's
Mhm.
expensive, but when you're coming down to nickels and dimes on performance and health, there's that. And I think of a quick story with I think it was ALCAT. That was one of the ALCAT. They were one of the first
Mm.
kind of at home sensitivity panels. And I don't even think they're around anymore because, again, I don't think they were very, like you said, throwing darts. I don't think it was very clear. In fact, I want to say they had did a study. They took blood samples from the same person, but sent them from different addresses and different names, and the panels came back different, which
Yeah.
because it's the same sample. But
Match samples are the way to test whatever lab you're using.
right. However, I started to think about them with your story because with LCAT, they would give you your results, but they would also give you a food plan based on what you were sensitive to and put you on a 4-day rotation. So every day you were having a different vegetable, a different starch, a different protein, and a different fat. And people did very well on these diets because they thought, oh, they got all my food sensitivities. But to your point, the way that rotation was built, you were always starting something new. So those guys, those hypervigilant guys hanging out in your lounge could never detect the broccoli because by the time they found the broccoli was gone.
Yeah.
So that was very interesting. Thank you for that story.
Yeah. And basically, anybody that eats the same thing every day is going to end up sensitive to some component of it. It's almost inevitable given the way the immune system works.
And to your point, when my husband and I did it, he would have oatmeal every morning for breakfast, and he's Italian, so lots of olive oil and salad. And the two biggest things that flagged for him were olives and oats.
Yeah,
What
that's,
would an Italian do without olive oil? I don't know, but after putting the rotation, sure enough, you retest and then it's better.
yeah, yeah.
Not that happens with everything. I wouldn't want to ever try gluten or dairy because my life is
Oh,
definitely better without it.
yeah, no, it's fascinating.
It is.
Um,
It is. So to just put a cork on this one, to just recap
okay,
that question, no,
yes.
FSM can't tackle food sensitivities by itself. It is a great adjunct to all the things that we talked about and
Well,
helps support the patient with,
it's actually an adjunct that makes the process so much faster and easier. Getting over food sensitivities without FSM, 18 months, 12 months, it's a
right,
pain.
right.
FSM, you can get it down to 3 months.
Yeah,
And what I tell the functional medicine community or the docs that do functional medicine that come to the core is what FSM gives you is compliance. You
compliance.
tell somebody to go on a rotation diet and their eyes glaze over and they roll their eyes and leave. That's the last time I'm going to see them.
Yeah,
And then you say, okay, it's 6 weeks and this is what you need to do.
yeah,
Oh, you can do it. You've been sick for 12 years. You can give me 6 weeks.
yeah,
And then you use FSM, it speeds up the process. They start feeling better faster
yeah.
and the belly stops hurting, the brain fog clears up, especially if they're coming in 2 or 3 times a week. They haven't bought a custom care yet, but you run concussion in Vegas and oh, brain fog gets better if you look at all the things that the Vegas does.
Yeah.
It's yeah, it's really a valuable adjunct is an understatement, but it
Yes.
buys you compliance so that they will do the other things that they need to do.
Because there is a lot.
Yeah,
And they can get energized and they also can get grumpy. There's that too.
true story.
Okay, now you have stuff to say, so thank
I
you.
do.
Yeah.
Yesterday, I have a patient that has a genetic neurologic condition that the basic mechanism of it's rare. It's called SPG7. It's a gene that codes for, it's a gene in the mitochondria that codes for protein. And this gene doesn't work, so it folds the protein wrong and
Mm,
poisons the nerve cell body in the peripheral and the central nervous system. And it starts with leg weakness and toe drop and then works its way up. until it hits the diaphragm, and then it hits the swallow mechanism, and then they die. And it hits, they have the gene since birth, and then they get to age 40-ish, and that's when it starts. It always manifests in adulthood. So this patient started coming in 3 years ago, and we treated the spinal cord and the nerves. So she comes, she stays a week. They come back 6 months later. They come from Texas. They stay a week. We started with the spinal cord and the nerves. The foot drop got better. Then she came in 6 months after that, and treating the spinal cord and the nerves didn't do anything. That's okay, that's weird. So we moved up into the brain, the cerebellum. She had a resting tremor, the basal ganglia, and the sensory motor cortex. That slowed it down. And we just used 528 from the solfeggio to repair DNA. I didn't use abnormal protein accumulation until maybe a year ago.
Right.
And treated the brain, and then we're back to the spinal cord. And not only is she not progressing, she's actually improving. So she went from a hard plastic brace for the foot drop. That made it worse. Then she went to an AFO, which is a lighter version of preventing foot drop. Now she just basically wears a particular kind of shoe. And so she's goes to the neurologist, and he says, "You're doing fine." They do breathing tests. She's doing good. Yesterday, I had 8 machines on her, one for the spinal cord and nerves, one for the mitochondria, one for different brain parts. And then her husband was in the room, and he said, this really got worse after she had COVID. That wasn't in my list at all.
Right.
Wait, it got worse? Yeah, actually, that's when the symptoms started, was after she had COVID. That was about 3 years ago. Okay. So COVID, I know ACE2 receptors are in the blood supply, in the kidneys, the liver, the heart, the lung, the brain. That's what I'm used to.
Right.
So I got out my trusty search engine on my phone, and are there ACE2 receptors in the mitochondria? There are ACE2 receptors in the mitochondria.
Wow.
Yeah, who knew? So I set up another machine from neck to feet, and I ran the 6 virus frequencies in the frequency we have for the mitochondria as a whole. And it was an hour. They ran a long time, and the softening was, there are actually 3 frequencies for the mitochondria. So I ran it on all 3. And I had a preceptor in the room that's an MD that's relatively new at FSM. And he said, "So what are you feeling for on her arm?" I said, "I'm just feeling for softening." And he said, "How does that work?" And I said, "Have a seat." So I put him in my chair, my rolly stool. I said, "No, just lay your hand there," and went to the frequency for that virus in the mitochondria. And he went, "Oh, it gets soft."
Yeah.
Now let me pause it. So I paused it, and I got firm. So we have in the advanced, that's the other thing I did last week, was went to the beach, and 423 slides later, we have a 4-day advanced.
Wow.
And there's the regular slide on long COVID.
Right.
And now there's another slide that I built today on the ACE2 receptor in the mitochondria. Who knew? And so you look at the fatigue that's associated with long COVID, the brain fog. You look at the post-exercise malaise, you look at cardiac troubles, congestive failure.
Yeah.
Where is the highest concentration of mitochondria in the body? Heart, the brain, and the skeletal muscle. What's affected? A lot by long COVID.
Yeah.
Fatigue, brain fog, muscle pain. Oh, it's just, who knew? And if
Not I.
looking things up, that's what makes us different. And so
Yeah.
I'm encouraging people, if you, yeah, every day I get reminded I don't know it all.
I think that's a great space to be in, because every day you get to learn something. If every day you think I don't know it all.
Low Bodham threshold.
Right. Yeah. The long COVID has been an epidemic, just like COVID was, with, I think, much less support. People are not believed. People are left to searching things out on their own and trying to patch what works for them together.
Well, and the other thing, pardon my, it's not skepticism, but it's really, this is what you're going to do? They put a nicotine patch on a 10-year-old? No, right? It's nicotine binds to a receptor that you need to improve its function of, but then what do you do? Is that
Right.
actually fixing the problem? No.
And that you said a lot in that little piece right there, is that fixing the problem. I think about so many modalities are just temporary not even solutions. They're just temporary. I don't even want to say fixes, because they don't fix anything. They're just
Compensations?
maybe it's just a
Something.
it's just a temporary band-aid that people are slapping on so that it looks like they're improving. So when I have a consult, or I'm talking to somebody and we're doing a reevaluation, and I'm asking questions like, why does it hurt when you do that? And they're like, what do you mean why? It just does. But let's think about what is happening that's causing this to irritate you, to cause pain. And it, sure, sometimes it's a little muscle test or biomechanics assessment and you can figure it out, but sometimes there's so much more. What were you eating 2 days before this flare? Because a lot of my athletes will talk about the workout that they did or the game that they played. And then you can start asking the dietary questions, the emotional questions. Did you have a fight with your girlfriend? Oh yeah, how'd you?
Just curious.
A hunch, but
Stuff happens.
maybe.
Yeah.
Someone's scholarship is at risk. Someone's contract is at risk. There's so many layers to an athletic injury that I would have never gone down because I had no way to treat it. If I even knew the answer, I'd be like, okay, so that's good to know. So our treatment strategies and our treatment approaches with FSM become layered and multi-machined and multifaceted because of the spectrum of,
Things we can treat.
yeah, I wanted to say that a little bit more professionally and eloquently, but that's essentially what it is. There's just more out there for us to have to look at.
And then there are things like I had a patient, the last time I saw her was December of 24.
Yes.
So I haven't seen her for it's almost a year and a half. And she, back then, I worked on whatever she had going on, but then it was like, dude, you need your hip replaced. And she was like, okay. So it took her a year and she had it replaced December 8 weeks ago.
Okay.
She came back in and she said the PTs are working on me and I'd get bruised and sore. And it's okay. I'm gonna see Carol on the 13th. And she came in and said, oh, good. I just love. I did a minimal sort of exam because scarring from a posterior hip replacement is just so easy. Scarring in the nerves, scarring in the fascias, torn and broken in the tendons, scarring in the periosteum. And then just out of habit, I put my hand on her other leg. So it's her left leg that had the hip. Put my hand on her other leg. She said, oh, that tickles. And I went, tickles? Shouldn't tickle. this leg isn't ticklish. So I went and did my little pokey wheel thing, and she is hyperesthetic, L2, 3, 4. She did say before we started working that it just low back pain, and better when she leans back, worse when she leans forward. Do you have any leg pain? No, no leg pain. Okay. But she's ticklish. So I took the little pokey wheel down her leg, and she was hyperesthetic from L2 to L5. S1 was fine.
Right.
That's okay then. So I put a towel under her low back, and I just treated inflammation of the nerve on the left leg,
Yeah.
and disc repair on the low back from the back to the abdomen, and then started to work on the hip. And of course, because of all the trauma she's been through in the last year, and the surgery and the pain and all that, concussion in Vegas from neck to chest. And then as we got the scar tissue in the adductors and the femoral plexus and the sciatic and her butt muscles start firing, and she can internally and externally rotate the hip. That was pretty cool.
Yeah.
Then I heard your voice in my ear about she needs to feel safe. So I rolled another machine over. And this conversation that was going on Facebook last night about, oh, multiple machines. They're going to do bad things. It's went from her neck to her feet and run 40 and 89. She has to feel safe to move this hip.
Yeah.
She fell asleep. Like it's the only thing I did that just, and that ran for almost 20 minutes while I was finishing up with the scar tissue in her leg.
Right.
And then torn and broken in the tendons. Set up another machine just to run torn and broken in the tendons.
Yeah.
And then when she woke up, it's okay, 40 and 89 is done. Feels safe when I roll the hip. Then did increase secretions in the cerebellum. It said, now externally rotate your leg. Oh, I can do that. Internally rotate. So getting her used to moving it. And then go straighten your leg. Oh, I can do that.
Yeah.
And then, so it all worked together. Went over to the other leg. It's not ticklish anymore. Sensation is now normal. She didn't have any nerve pain. She perceived it. She is so good at pain control that it was just ticklish. Then got her up off the table, and without FSM, had her just shift her weight from side to side.
Right.
And then do toe heel walking.
Yeah.
And then, okay, why don't you just stand on your right leg? Okay. Now stand on your left leg. And she looked at me with this panic. It's okay, I won't let you fall.
Yeah.
And it's like retraining her system.
Yeah.
And I'll see her again tomorrow. Are you sure it's going to take 2 visits? Oh, yeah. Everything from your feet to your neck is going to have an opinion about the fact that your biomechanics just totally changed.
Yes.
And so that was my day yesterday.
Oh, I have so much to jump in on that. It was so hard for me to just bite my tongue and listen, because the movement and the safety has been my passion project for the last couple of years, and seeing it move into fruition with the FSM rehab course as I'm finishing up the practicums and the slides. And you and I had our own little Zoom call. I think it was New Year's Eve. We decided to just do our own podcast just without people.
Yes.
And as we were talking about all the things that are going to go into the upper and everything that's going into the lower, you're like, you do know this is a lot of material. I'm like, oh, I know. And the one thing that I love, and it's in the sports course, is the work that we do on the balance pads. And I prescribe balance pads to so many of my rehab patients, because that little bit of instability, that little bit of proprioceptive feedback where, the receptors in the feet, through the ankles, through the knees, through the hips, there's all these little micro corrections that are happening, giving feedback. And people don't think it's a big deal, But even integrating it, bringing it to the bathroom when they brush their teeth and wash their face, the people that are cooking, put one by the stove or put one by the sink or the counter while you're peeling vegetables. It's so easy to jump on it to just get that feedback of, oh, this feels different, but guess what? We didn't die and this wasn't dangerous. So all these petitions, that conversation that's happening, where am I going? You're safe. Just keep peeling carrots. But I don't know where my foot is. Just keep peeling carrots. And then it's happening. And then they go onto the floor and take a deep breath. And wow, that feels. And of course, we don't want to overload the nervous system. So it is splicing it into their rehab in small increments. But we have to feel safe. We can't expect scar tissue to dissolve without collateral damage until we can get muscles sliding and firing the way that they're supposed to. And so that is just it's a huge part of the process of it's not just running 13 on A, dissolving scar tissue and letting them go, because those people that you just do that to are going to come back in with more pain, or at least all the people are
And
going to come.
someplace else.
It's going to be somewhere else or in the exact same spot because their nervous system is, I don't know what you did, but you left me feeling vulnerable. And now everything else has to tighten up in the wake of this treatment.
And that phrase we use, everything is connected to everything.
Right.
I have a patient that is actually it's weird because he has no pain. And he's here to shadow me for the week and be a patient.
Okay.
And it's the right side of his first day, his neck was symmetrical, the supine cervical practicum. Second day, right side of his neck is tighter. And then he mentioned something about his right knee. So I went and tested the right knee and the left knee, and the right knee was just a little bit of side tilt, side slide. What did you do to your right knee? Oh, that was a blah, blah, blah. And it was just lateral collateral ligaments and coronal ligaments, just a millimeter, 2 millimeters, sloppy.
Yeah.
Went down on his right foot and his right ankle. He said, oh yeah, I sprained that ankle. And then I had him swing off the table, put his feet on the floor, and his left arch is high, his right arch is flat. Oh, okay, so your right leg operates differently than your left leg. So what you need is to tighten up the ligaments in the ankle and the knee, but you also need an arch support to bring your right arch to the same height and pronation control that your left arch is.
Right.
So running from his knee to his foot, torn and broken in the ligaments for an hour while I'm working on his neck. And then and he had taken the course before. So then the right side of his neck let go because the right leg and the right knee, and it's all the way up. It didn't even cross the chain. It was just all the way up the right side.
Yeah.
And it's in terms of rehab, the solution for his neck is super feet arch supports for his feet, and torn and broken in the ligaments in his knee and his foot. And then we'll see what tomorrow brings. But rehab is recognizing that anything you do downstream is going to end up here.
Yeah.
So you work on somebody's neck, but you don't check that. He didn't have any pain in his leg.
Yeah.
As far as ankle, his knee.
Right.
But everything's connected to everything.
Yeah. That's a good t-shirt. We have some.
We do.
Yes. For those clients that fly in to see you for 4 days, what are the best practices to avoid overdoing it with them besides using the frequencies? This person has a client coming in from out of state, 16-year-old male who at 10-month-old baby had a neuroblastoma wrapped around the spine T10 to L4. He
Yikes.
did extensive surgery to remove the vertebra, remove the cancer tissue, replace chemo. He recovered.
Whoa.
He recovered and went on to be a hockey goalie for 8 years, quit 2 years ago, now has a lot of pain and has been tested for everything. Um,
Wow.
under the
Um,
sun. O'Shea goes on to say here, tested for everything under the sun. Doctors are thinking scar tissue. I'm still awaiting to get all surgical and imaging reports. BIVSS equals 3, but has balance issues. Undoubtedly, a lot of tissue affected. She did the basics, 124 with tissues before running scar tissue, 13, 58, 51. Framing
where,
advice.
oh, there it is. It's down here.
Yeah, I went down there.
Whoa. How old was he when he was 16? No, he's
He's
10 months
16 now, and
old.
he was 10 months old when this was going on.
Whoa. T10 to L4. So lots of pain where? That's the first question. And T10 to L4 is a huge sympathetic verteplexus at T12 that you have to look at. And whoa. More about the hockey goalies. Ugh. I just remember the movie Miracle and what that goalie had to do and what goalies do.
So
Um,
goalies have a lot of, so he talking about balance issues. VIBS is low, but hockey goalies are very flexible, especially good ones. They can do the splits, they can maneuver a lot more than they're like little gymnasts. Well, they're
yeah.
like large gymnasts. So the pain could be from just laxity in the joints from being a goalie. That's not uncommon.
The thing is that the whole middle part of his spine from
Has
T10 to L4 is locked up.
one of the questions was she'd written they did extensive surgery to remove the vertebra.
Yeah, they
So
put it up.
having structural changes in the spine when you're an athlete is challenging.
Adhesions in the dura
Yeah,
from the brain to the tailbone. And that was the other fun thing about doing the advance was I really got into the weeds with the layers of the dura and
yeah,
what they do, the subarachnoid space and the ligaments that attach to the nerves. So the first thing, Suzanne, is physical exam.
yeah. How is he presenting
Reflexes,
with her?
it's if the mid-thoracics, so T10 to L4, if the whole middle part of your trunk doesn't move, then you rotate and that part of your body can't rotate.
Right.
So there's more strain in your neck. What are his reflexes like? What's his sensation like? Is this nerve pain? Is
Yeah,
it
where is his
joint
pain? When is it
pain?
happening? Yeah.
Is it
I wouldn't run a ton of
pain?
58 if it's in the viscera, fine, but I wouldn't run it on extremity tissues. I wouldn't
No.
waste
And
time.
I also, you have to, this is the way I treat people in a 4-day period is using 8 or 9 machines. So
Yeah.
you treat the nerves, you treat torn and broken, and the, the connective tissue,
Trauma in the connective tissue.
trauma. Oh, that was the other thing. I ran trauma in the connective tissue, and she just went,
It is just a religious
oh,
experience.
it was wonderful. And so it's not something to do if the only thing you have is a custom care. You
Yeah.
it I have 4 or 5 precision cares in my office. I have got way too much equipment, but you could do similar things if you kept a laptop in your office and custom cares and were willing to reprogram them for what you needed.
Yeah.
Overdoing it is not a thing. If he's had this since basically infancy, you can count on 40 and 10 being a piece of it. So cord sensitization, if the only reason Jay Shaw comes back every year or every other year is to make us aware of cord sensitivity, it's worthwhile.
Yeah.
Central sensitivity is unlikely in an athlete. They tend to have very good pain suppression neurology. Then adhesions in the nerve, adhesions in the dura, where's his pain, what are his reflexes, what's his sensory exam, even joint pain. His knees hurt, his elbows hurt, his ankles hurt. Okay, that's 40 and 10. That's the
Yeah.
spinal cord. Look for a disc bulge in his neck.
Yeah.
And if 10 to 4 is fused, a goalie rotates his trunk a lot, and that's going to shear the disc.
That's
So
what I was thinking right away. Yeah.
yeah, so you're going to have disc bulges is probably 7, 8, or 9, and L5S1, L4, 5. So sensory exam at those levels. And yeah, that's what I can think of. Overdoing it is, I haven't overdone it yet. It's a thing.
And then Louise had jumped in on that, I think, and had asked, does the COVID vaccine affect the ACE receptors? A lot of people have side effects.
Yes. No, it's the vaccine is an artificial infection. So it's exactly the same mRNA. RNA is a chunk of the virus that has all of the antigens that the virus has, or all of the, at least that's the way I think of it. And so I treat them the same, whether you had COVID or got vaccinated and then had COVID 6 times, it's the same. MTHFR, 40%, tested positive, one form COMT. Can have considered fast or slow, reminds me of vagus function rest, but says the whoever DNA is, the connection, what we have to explain is the connection between.
We might have to read the question a little bit for people that are just listening.
Sorry. I signed on a little late, so I may have missed if you addressed this topic. No, we didn't. MTHFR, which is methyl folate receptor, is supposedly in 40% of the population. Many of my relatives tested positive for different forms of this genetic variant. What I'm curious about is that one form, catechol-O-methyltransferase, can have considered either fast or slow, reminds me of vagus function, rest and digest versus fight or flight. Has anyone come to either of you needing assistance with this mutation? The way you're thinking about it is a little bit sideways. So if you have an inability to methylate, it's common these days to test just for the methylation gene. And you have to be able to methylate folate and methylate B12. And then they say, oh, you can't methylate, and methylation is important in genetic stability and preventing cancer and brain problems. The methylated form of B12 and folate acid is the active form. They give you methylated folate, and in 3 days, you're agitated and anxious, and in 5 days, you say, I don't know what's wrong with this stuff, but I don't like it. So you just stop taking it and you don't tell your doctor about it. And 20 years later, you end up with dementia or peripheral neuropathies or some form of cancer.
Right.
Okay. COMT, catechol-O-methyltransferase, is an enzyme that demethylates. So you have 2 processes. One that you have to be able to methylate folate and or B12, because those are 2 slightly different genes.
Right.
And you also have to demethylate epinephrine and norepinephrine in the brain. And there are only 2 ways to do that. One is an enzyme called catechol-O-methyltransferase, COMT. There's 5 or 6 different elite forms of that gene, you have all 6 of them. And there's only two ways to demethylate stress hormones in your brain. One is exercise that makes you sweat, and the other is this enzyme. So when you, I got lucky because 23andMe was still in existence, and one of my patients told me about NutraHacker, which is the interpretation site that 23andMe sends you this little text box with your complete genome in it. It's completely useless. 23andMe is only allowed to tell you whether you're European or Somalian or African or South American or whatever, Neanderthal. And you have this little text box. We take the text box and you send it to an interpretation site. There are a number of them, Genetic Genie, and I use NutraHacker. If you don't have that option, but their MD has tested them for methylation, and you're not sure what their COMT status is, ask them what they do for fun.
Mhm.
Oh, I go running 4 days a week, otherwise I'm a crazy person. Okay. Well, yeah. So I don't even have to ask your COMT status.
Right.
We already know.
Yeah.
And with me, when I was younger, up until the time I was about 50, I was always riding my bike. I ran every place I went as a drug rep, even in 2-inch heels. Then I was hiking. I was always moving. And when I got my COMT results, I am missing one of them completely, and I have SNPs in the other 4. It's like I can't demethylate.
Right.
Over time, I figured out I can take methylfolate, a huge dose, 5 milligrams, but I can't take methylated B12. I take methylated B12 and I'm a wreck in 3 or 4 days. So you can do it. And then if you can't take methylated B12, you take adenosine hydroxy, and you can take methylfolate or you can take folic acid, but you can't turn it into the active form. So as it turns out, I can take methylated folate, but I can't take methylated B12. So you can do it with the genetic testing. I understand 23andMe is not a thing anymore, but
I still have access to my portal, so I don't know.
with any luck, it's still around because the interpretation sites are what really makes it valuable.
Yeah. Yeah.
And
Sorry,
but
my alarm.
you can tell, oh my God, your alarms are going off. But you can tell by doing a trial and error thing with your patients and just asking them what they do for fun. That tells you their COMT status.
Right. I do want to just get to that last question. I don't leave anybody hanging. So, does treating trauma and the connective tissue mean running 9/321 on 142? No. So 9 is histamine or allergy, 321 is the paralysis, and 142 is fascia. So for me, trauma is running 94 or 294, depending on where you're running it. And connective tissue is 77, 142 is fascia. So that's my
Yeah. And trauma in whatever.
whatever. Yeah, exactly. We were just using connective tissue as an example, but
Because of the hip.
yeah, for one of the goalies that I worked with, it was trauma in the periosteum because dropping down into the splits, he had a fracture in his pelvis, stress fracture.
Ow.
And running inflammation and torn and broken the periosteum helped, but it wasn't until we went back to do trauma in the periosteum and pain subsided. Yeah. Oh,
This
thank you.
hip replacement patient, I'm getting towards the end and there's still a certain amount of tone that didn't feel right.
Yeah.
And I thought, okay, they put this pin down inside her bone.
Yeah.
I wonder, and I ran trauma in the periosteum and trauma in the bone, and that's when the muscles let go.
It just makes sense.
Yeah. and then torn and broken in the bone. So if you think of microfractures, especially up near the top where the pin goes in,
that's what's happening.
and it's thinking about things in 3 dimensions. It's FSM is for people that like to think.
And I love it.
Yeah. And
Right.
I was talking to JJ earlier, and I said he was talking about how there are so many different frequency systems out there and frequency websites and frequency lists. And I said, yeah, and we're the ones that they're chasing.
Yeah.
It's like we started it, FSM started it, and I want to keep the bar here.
Yeah.
They can be wherever they want, but for us, it's thinking in 3 dimensions, keeping the frequencies authentic, verified, validated.
Yeah.
You don't just muscle test for some random frequency or
and then throw it on. No.
Get a list from somebody who muscle tested it for it or had their no.
Yeah.
I like the bar where it is. I
Me
like
too.
our practitioners because we think.
Yes.
Yay.
That's it.
Okay.
So we got to save it all for next week. Just keep
Yes,
adding to my list. But we did good work today. I'm proud of us. We tackled some big topics.
Thank you for asking. That's like, yay for us.
Yeah, we can do hard things.
Yeah, we can do
All right,
hard
everybody.
things. I love it when you say that.
Thanks for coming.
Thanks. See you next time. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.